It's really enjoyable to be every year here in GIS, very big conference, and I'm really advising everybody to attend every year. My case for today is really to use the ECMO. We have the usual, which is unusual problem. So usual problem actually these days to have severe aortic stenosis at the same time with severe ischemic heart disease. So my case for this scenario is 76-year-old diabetic hypertensive patient with severe ischemic heart disease with recurrent PCI. The last one was 1 week prior to getting him, and at that time he had the RCA intervention, which was so difficult because of the accesses. So it was done through the right femoral artery. In spite of that, the patient continued to have significant anginal pain and his blood pressure on the low side all the time, with blood pressure of 90/50 on average. So the patient has severely impaired left ventricular function, ejection fraction of 20%, severe aortic stenosis, low flow, low gradient, mean gradient of 24, and the aortic valve area is 0.75. And we have significant access problem that the radials were gone because of the previous PCIs, and the common femoral artery is dissected, the right common femoral artery. So this is the RCA, how it looks like. You can see that the stent there and distant restenosis and no flow to the distality. And the significant instant restenosis in the left main, and you have also lesions in the circ, and the most significant is that the LAD is severely diseased in the mid segment and the distality. So we have difficulties in this case. In summary, that the patient having continuous chest pain, and he has multiple risk factors. Ejection fraction is low, and blood pressure is low. Severe aortic stenosis, severe left main instant restenosis, and the LAD is not graftable, and you have no radials, and the right common femoral artery is dissected. So our strategy after discussing the case with the surgeon and what is the best plan to do for him is to go with induction anesthesia, and then to go for VA ECMO from the left side. So we'll be able to do something. And after that, to go for surgical repair by the surgeon to the right common femoral artery. So we'll be able to insert the sheath for TAVI, and to have the big tail catheter because you need it for TAVI, so through the left ulnar artery. And to do PCI to the left main instant restenosis by doing a DK crush technique through the right common femoral artery, the one that just repaired and the sheath inserted in. And overwire pacing, and to go with the TAVI through that sheath, and then to discontinue ECMO inside the OR. This is our plan. So the CT for TAVI showed that at least the coronary arteries with a proper height away from the aortic valve. And there is not much of calcification, and the femoral artery, the common iliac artery. So as you know, the only thing that the dissected right femoral artery is the problem. So as the plan, the anesthesia was started, and ECMO initiated from the left common femoral artery and vein, and the surgeon repaired the right common femoral artery where the sheath was implanted, and then went to the RCA and fixing the RCA with the DCBs, and then the left main with the DK crush. You don't need these details. So the result was good, and after that we moved for TAVI with the MyVal 24, I think, and implanted well, and sorry, having this successful result. The success was immediate, showed immediate improvement of ejection fraction to 40%. The ECMO was removed inside the cath lab, and surgical closure for both femorals was there, and the total time of ECMO was 2 hours. So the most important point of discussion why to do it this way, that as you know, when you have severe ischemic heart disease, significant left main is a main problem when you will go for TAVI, because when you pace, you take the patient in a scheme in which the patient may not tolerate it. So the options by doing either the TAVI first or doing the coronary artery disease, this is a big discussion. But to avoid the complications and the problems, ECMO was the saver. And to do the prophylactic ECMO is better than to do it in the emergency. There is no direct comparison between the two options. The only reports are case reports in the discussion. So it should be reserved for patients with high risk for hemodynamic collapse. And these are the all available references. So my conclusion from this case that it's not unusual actually to have cases where you have our severe aortic stenosis, severe left main disease. And in high risk patients, you do to go for prophylactic support is better. And the ECMO was the option in this case. And the teamwork is very essential in the success. Thank you.